بسم الله الرحمن الرحيم. I'm Dr. Marwa Munir Rifai. Now we will discuss bronchial asthma. What will we discuss? Mainly the anti-inflammatory drugs and its role in bronchial asthma. Introduction: corticosteroids, mast cell stabilizer, leukotriene receptor antagonists, antibodies to immunoglobulin E, monoclonal antibodies. And in each class we will discuss members, kinetic, dynamic, actions, side effects, uses, and if there is any contraindication. Bronchial asthma is defined as it's a state of hypersensitivity and inflammatory disorder of the bronchi characterized by airflow obstruction. This disease characterized mainly by inflammatory disorder associated with bronchospasm and edema with mucus secretion. So the main pathology depends on occurrence of hypersensitivity and inflammation, bronchospasm, and third, edema and mucus secretion. Again, first, inflammation and hypersensitivity. Second, bronchospasm. Third, edema and mucus secretion. So this patient is manifested by cough, chest tightness, breathlessness, wheeze, and according to this pathology, we will choose the drug groups which can benefit the patient of bronchial asthma. This picture illustrates the difference between the normal bronchi and the bronchi of the asthmatic patient. Normal bronchi has normal diameter, relaxed smooth muscle, no excessive edema or mucus secretion, but in inflamed bronchi of asthmatic patient, there is tightness of the smooth muscle and constriction, swelling, edema, and mucus secretion due to inflammation. So, the treatment of bronchial asthma concentrates on bronchodilating drugs, anti-inflammatory drugs, and mucolytic. The first drug group as anti-inflammatory, corticosteroids. There are three forms of corticosteroids: inhaled, oral, or parenteral. Inhaled, such as piclomethasone, budesonide, fluticasone. Oral, as hydrocortisone or prednisolone. Parenteral, as dexamethasone and also hydrocortisone as a parenteral form. This picture illustrates the dynamics of corticosteroids, how corticosteroids act as anti-inflammatory agents. On the left side of the slide, the inflammatory cells, eosinophils, mast cell, macrophages. It's controlled by corticosteroids, and there is minimizing the number of these inflammatory cells and decrease in the cytokines. Due to its anti-inflammatory effect, this is followed by decreasing the cytokines, mediators, decrease mucus secretion, and bronchodilating effect due to its beta-2 receptor upregulation. So we can told that corticosteroids can control the main three causes of the pathology of bronchial asthma. It controls inflammation and decrease inflammatory cell, and this is followed by decreasing the cytokine release and inflammatory mediators. Then there is decrease in the mucus secretion with upregulation of the beta-2 receptor. The most effective class of drugs in treating the asthmatic patient is corticosteroids. They suppress inflammation, immune response, but corticosteroids don't have direct bronchodilating effect. Pharmacokinetics it should be given by inhalation or maybe intravenous or orally in chronic asthma. Corticosteroids act on intracellular cytoplasmic receptor, and following binding with its receptor, it forms complex that pass to inside the nucleus and controls the gene expression. This slide illustrates the anti-inflammatory effect of corticosteroids. First, decrease the edema of the airway and leukocyte recruitment, decrease inflammatory cell infiltration and cytokines, decrease production of inflammatory prostaglandins, upregulation of beta-2 receptor, and also it increases activity of M2 autoreceptor, and this can decrease the bronchoconstriction. All of these actions is followed by decrease excess epithelial cell shedding and bronchial epithelial edema. But there are several adverse effects of corticosteroids. Inhaled drugs should be given in large volume spacer to decrease the side effects. Inhaled corticosteroids is complicated by dysphonia, hoarseness of voice, and oral candidiasis. So it should be given in large volume spacer. But inhaled corticosteroids has localized effect, but in high doses it can give systemic side effects. The adverse effect is due to prolonged administration of corticosteroids or in high doses may lead to osteoporosis, elevated blood glucose, peptic ulcer, growth retardation, mood changes, glaucoma. And this table summarizes all effects of corticosteroids on different systems, not on the bronchial tree only. Corticosteroids on the metabolism increase glycogen lysis and blood glucose, increase lipolysis and free fatty acid, and has negative nitrogen balance. So it's complicated by increased blood glucose, moon face and buffalo hump, and growth retardation. So that's contraindicated in diabetic patient. And on electrolytes, it is salt and water retention. And this leads to edema, hypertension, hypokalemia, and hypocalcemia. So it's contraindicated in hypertension, heart failure, osteomalacia, and osteoporosis. Also, corticosteroids has anti-inflammatory effect and decrease the immune response. So it may lead to repeated infection. It increases the gastric HCl, and this leads to peptic ulceration. Due to its immunosuppressive effect, it can be used in allergic condition and in autoimmune diseases. It increase the RBCs and blood coagulability, but decrease white blood cells and lymphocytes. So it can be used in leukemia and lymphoma, and contraindicated in the thromboembolic disorder. Sudden withdrawal of the corticosteroids may lead to adrenocortical insufficiency. So it's absolute contraindication to stop suddenly corticosteroids. Corticosteroids increase the lung surfactant in fetal lung and lead to lung maturation. And it has uric effect. The second group is mast cell stabilizers. One of the most important inflammatory cell is mast cell, and it contains a huge amount of histamine. Due to anti-antibody reaction on the mast cell and rupture of its wall lead to release of a large amount of histamine, which has a main effect in mediating bronchospasm, inflammation, and edema in the asthmatic patient. So, stabilizing the mast cell and keeping its normal membrane prevents the release of excessive amount of histamine. But this group is used mainly in prophylaxis, not in acute attack. Also, it's used in seasonal allergic rhinitis and allergic conjunctivitis, such as ketotyphon. This slide illustrates the main effects of mast cell stabilizer, ketotyphon. It stabilizes the mast cell and prevent release of histamine and inflammatory mediators. And substance B inhibit the accumulation of eosinophil, neutrophil, and macrophages in the inflamed lung, inhibits the production of immunoglobulin E. Third group is leukotriene receptor antagonist. Leukotrienes are considered one of the main mediators, inflammatory mediators in the pathogenesis of bronchial asthma. So, there are two groups to prevent leukotrienes. Either leukotriene receptor antagonist or lipoxygenase inhibitor. And these two groups are so important in preventing aspirin-induced asthma, because aspirin-induced asthma depends mainly on leukotrienes. So, leukotriene receptor antagonists or lipoxygenase inhibitors are the main drug groups used in treating aspirin-induced asthma. Now we begin with the leukotriene receptor antagonist, examples montelukast and zafirlukast. Mechanism of action: it's given orally in prophylaxis of asthma with inhaled corticosteroids. They block the sustained leukotriene receptors and prevent mediating the inflammation in asthmatic patient. So it decreases irritation and inflammation, edema, and mucus secretion in the bronchi. Adverse effects lead to elevation of the liver enzymes, GIT disturbances, and headache. The second group in preventing leukotrienes is 5-lipoxygenase inhibitors. And 5-lipoxygenase inhibitors as the xylitone prevent the formation of leukotrienes. It's used mainly in long-term prophylaxis, and it's a drug of choice in aspirin-induced asthma. But xylitone is hepatotoxic. In summary, to prevent leukotrienes, we can prevent the formation of leukotrienes by inhibiting 5-lipoxygenase enzyme, which is responsible for formation of leukotrienes from arachidonic acid, or blocking the receptors of leukotrienes. Both drug groups used in long-term prophylaxis, not in acute bronchial asthma. But the two groups are the group of choice in aspirin-induced asthma. 5-lipoxygenase inhibitor as xylitol is hepatotoxic, but leukotriene receptor antagonist as ferrolocust and mentolocust, and also have hepatotoxic effect. Now we will discuss monoclonal antibodies to immunoglobulin E, such as omalizumab. It's a recombinant immunoglobulin E monoclonal antibody. So it prevents the antigen antibody reaction on the mast cell and prevent the release of large amount of histamine. But omalizumab is used only in persistent severe allergic asthma, resistant persistent asthma. Over 12 years, who not controlled by other therapy of asthma. Omalizumab is given subcutaneously every 2 to 4 weeks, and it has very long half-life, about 26 days. It's complicated by anaphylaxis, headache, and allergy at the injection site. So we can conclude that omalizumab has long action, used only in severe resistant asthma, complicated by anaphylaxis, headache, and irritation at the site of injection, and it prevents the reaction between immunoglobulin E and antigen on the mast cell. So prevent the damage of the mast cell and release of inflammatory mediators, especially histamine. Is a monoclonal antibody omalizumab, and we told that it's only in resistant asthma and it has a long duration of action, about 26 days, and it prevents the antigen antibody reaction on the mast cell and prevent the damage of the mast cell and release of inflammatory mediators. And this is in summary all data concerning bronchial asthma. And now we will discuss some multiple choice question about this topic. Question number 1. Corticosteroids systemic complications include inflammation, number A, or number B, allergy, or number C, hypotension, or number D, peptic ulceration. Corticosteroids has anti-inflammatory and immunosuppressing effect, so it is not complicated by inflammation or allergy. So number A and B are false. Corticosteroids lead to salt and water retention and may lead to hypertension, so it's not complicated by hypotension. But it leads to increasing the gastric HCl, so it's complicated by peptic ulceration. So the true answer is D, peptic ulceration. Question number 2. Complications of inhaled corticosteroids. Inhaled form. Inhaled form A, candidiasis, B, sepsis, C, gingival hyperplasia, D, dry mouth. Oral inhaled corticosteroids are complicated by candidiasis, infection with candida. Question number 3. Acute attack of bronchial asthma can be treated by acute attack, long-acting corticosteroids, or mast cell stabilizer, or immunoglobulin E monoclonal antibody, or beta-2 receptor agonist. The most effective drug groups in treating bronchial asthma are beta-2 receptor agonists, either in acute attack or long-term prophylaxis. And if this group failed, we can use corticosteroids, short-acting or long-acting. But acute attack of bronchial asthma can be treated by beta-2 receptor agonists, not long-acting corticosteroids, not mast cell stabilizer, not immunoglobulin E monoclonal antibodies, because these three groups only for long-term prophylaxis. But in acute attack, we prefer beta-2 receptor agonists as salbutamol. Thank you so much. Please study well this topic, it's so important. And if there is any question, ask me on Telegram. Our reference, First Aid for the Basic Sciences. Thank you.